Ken, did you get patients asking you when they come with? I think that for oncologists, I'm pretty aggressive in the management of local disease. Because I think most oncologists, when we are fixated on distant metastases, we lose sight of the importance of local control. And there is nothing worse than to see a young guy or an older guy, not developing CRPC distantly, but developing, CRPC in the prostate bladder region, where these patients are often miserable because of pain, pelvic floor dysfunction, hematuria, obstruction, and so forth. So I do believe local control, where you do it with the intent of cure or delaying symptoms, palliatively in nature, is extremely important for our patients.
Yeah, I think that's one of the things that we do see once in a while, obviously more selected patients. And again, I think you could offer them radical prostatectomy, but again, I think that's like Neil said, the pendulum's swinging the other way. I think more appropriately is radiation therapy, because you can radiate, obviously, the primary, the prostate bed, lymph nodes, and get benefit of that as well. And then there's some thought about cryotherapy with the immunologic potential that happens during cryotherapy for local disease as well. But again, I think those are very specific patients.
So a lot, I think, still for us to work out, but, and I didn't mean to cut you off, Jorge, would love to hear, what are your closing thoughts, or what's the theme of metastatic hormone-sensitive prostate cancer from your perspective?
I think that what you just stated earlier, Neil, right after the case, I think is mind-boggling to me that in the United States of America, with the compelling data that we have, 6, 7 trials, with a hazard ratio for survival that you can tell a patient, I can reduce your risk of death by almost half, then our patient population is still getting suppression of testosterone alone. I think that to me is, I just cannot understand why it happens. It may require for us to go and educate, for us to teach, right? But at the end of the day, I think that the standard of care, should be throughout the world, is suboptimal when you do ADT alone. And I tell my patients, volume matters, intensification is needed, and if you don't get intensified, you're getting suboptimal care.
Absolutely.
I would echo the same thing. That's why I brought it up. I just think it's critically important for people who are watching this to just know, we talked a lot of subtleties, a lot of great data out there. Bottom line is, ADT as monotherapy is the wrong answer.
Fully agree. You guys summarize it perfect.
Agreed. So, ultimately, we owe it to our patients to have these conversations, to offer them combination therapy, and really, it is a rare patient for whom ADT alone is going to be the right answer. And we really need to make sure we think about combination first, and ADT alone as a very, 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 very distant second option, and perhaps not an option at all, shouldn't be an option for many of our patients. But thank you.